Antiaggregants and hematopoietic agents. Physiology of platelet aggregation. Blood vessel injury, it releases collagen. If von Willebrand factor is present, then it activates platelets. Platelets release GP2B3A, COX-1, ADP, and phospholipids. GP2B3A is inhibited by abcimab. COX-1 is inhibited by aspirin. COX-1 is inhibited by aspirin. So function of COX-1 is that it stimulates thromboxane A2, and ADP, it stimulates P2Y122. But ADP to this PY metabolite is inhibited by clopidogrel. Thromboxane A2 and this P2Y122 both causes platelet aggregation. Also GP2B3A also causes platelet aggregation, while increased phospholipids causes thrombin. And platelet aggregation then forms a permanent clot. Thrombin, it becomes protease activated receptor, which again causes platelet aggregation. But thrombin to protease activated receptor PAR to platelet aggregation. So this PAR to platelet aggregation, that step is inhibited by vorapaxar. Thrombin also inhibits the formation of fibrinogen to fibrin, and then it forms a MASH for the permanent clot. Antiaggregants. First is our aspirin. Mechanism of action: aspirin causes irreversible inhibition of COX-1, and that's why there is reduced thromboxane A2. The dose here is 50 to 325 milligram oral dose. Uses secondary prophylaxis, acute coronary syndrome and ischemic stroke, treatment of acute coronary syndrome, essential thrombocythemia, Kawasaki disease, antiphospholipid antibody syndrome. Side effect is bleeding. Pre-op, continue aspirin and stop clopidogrel 7 days before the operation. Continue aspirin and stop clopidogrel 7 days before the operation. ADP inhibitors and P2Y122 inhibitors. It's P2Y12R inhibitors. Classification: irreversible and reversible. So irreversible inhibitors are clopidogrel, ticlopidine, prasugrel. Reversible inhibitors are again divided into competitive and non-competitive. Competitive is cangrelor, which is an adenosine analog. T-half is 3 to 6 minutes, short acting. Route is IV. It is used in PCI in myocardial infarction. Cangrelor. Non-competitive is ticagrelor. It is long acting. Route is oral. Use again PCI in myocardial infarction. Treatment is for acute coronary syndrome and secondary prophylaxis of myocardial infarction. Ticagrelor, which is long acting, and cangrelor, which is short acting. Hit and run drugs: irreversible ADP inhibitors and P2Y12R inhibitors. Aspirins, proton pump inhibitors bind irreversibly to target. Increased T-half period. Clopidogrel, prodrug, acta point by cytochrome P2C19, it gets activated. PYP2C19 shows polymorphisms, blunted clopidogrel, decreased effect worsens MI. Metabolizes omeprazole. Competitive inhibitor of clopidogrel is omeprazole. Clopidogrel use is same as aspirin. It's combined with aspirin for patient on stent. Ticlopidin. It has increased toxicity and hence GI side effects are nausea, vomiting, diarrhea, agranulocytosis, TTP-HUS complex. Use secondary stroke prophylaxis in resistant cases. Ticlopidin. Prasugrel. Most potent plus fastest acting. Increased risk of intracranial bleed. Contraindication is history of stroke and transient ischemic TIA, and its use is PCI in MI. Prasugrel. Vorapixar mechanism of action. It inhibits PAR and its uses is secondary prophylaxis in myocardial infarction and unstable angina. Single agent combined aspirin, clopidogrel. Side effect: increased risk of intracranial bleed, contraindication in stroke and TIA. Glycoprotein 2B3A inhibitor. Mechanism of action: abcizimab blocks GP2B3A, which inhibits vitronectin. Other drugs: tibrofeban. Shortest T-half, maximum affinity, longest acting. Eptifibatide, longest T-half plus minimum affinity, shortest acting. Uses PCI in MI, acute coronary syndrome, route intravenous or intracoronary. Hematopoietic agents. Drugs acting on erythropoiesis. EPO analogs and EPO receptor agonists. EPO, that is erythropoietin analogs. Epoetin alpha, darbepoetin, longer acting, clinically preferred. Use: drug of choice in anemia due to chronic renal failure, dialysis, zidovudine, anti-cancer drugs, and premature infants. Side effects of EPO is hypertension, iron deficiency, thrombosis, pure red cell aplasia, flu-like symptoms. EPO receptor agonist, peginisatide, anemia of chronic kidney disease, CRF, chronic renal failure. Drugs acting on granulopoiesis. GCSF analog, granulocyte colony stimulating factor. So GCSF analog, increase potent, decrease toxic. Drugs are linograstim, filgrastim, most commonly used is filgrastim. Route multiple dose subcutaneous or IV derivatives lepifilgrastim and pegfilgrastim. Long acting, single dose in a chemotherapy cycle. GM CSF analog, G macrophage CSF, decrease potency and increase toxicity. Drugs segramostim, side effect capillary leak syndrome. Uses neutropenia due to myelodysplasia, aplastic anemia, HIV, and chemotherapy. Side effect is bone pain. Drugs acting on thrombopoiesis. Thrombopoietin agonist. Drugs romiplastim and L-thrombopelast. Thrombopoietin agonists are used in ITP, immune thrombocytopenia, cytopenic purpura. Names are romiplastim and L-thrombopelast. Side effect portal vein thrombosis and acute myeloid leukemia. New drugs avatrombopag and lusotrombopag. Prevent procedural bleeding and liver cirrhosis. Interleukin 2 analog, oprelvecin, use chemotherapy-induced thrombocytopenia. Side effect fluid retention in congestive heart and edema. We'll continue with anticoagulants and fibrinolytics in the next video.